you are and you are able to join us. We appreciate your presence. I want to welcome all CPANites here. Thank you. I'm still waiting to see our dear national chairman and other NEC members. I want to welcome all of us. Any fellow of our Great Society PSN, I salute you, all of you. Fellow of our dear college, I welcome all of you. We're going to start right now, and as they join us, we'll introduce them. Thank you so much for joining us tonight. Tonight, this topic, I've been searching to really understand this topic. It's not really what we used to see all the time. So I want all of us to get seated, get your pen and paper, and ready to learn new things tonight. We are going to bless today by our dear presenter, Dr. Emmanuel O. Chibuogu. He's a FAMD holder, MCCPAN, member PSN, and member FIP, as young as you are. He is a course member, Nasarawa State Camp. Maybe he's still inside the camp. We appreciate you. He was a former intern in Federal Neuropsychiatric Hospital, Benin, Edo State. Wow. Really YPG. We appreciate you this night that you want to really expose us to this great topic, avoidant stroke restrictive food intake disorder. Wow, ARFID. My dear colleagues, let's get seated and listen to our erudite scholar this evening, because this topic is unusual. We don't normally see this topic. So let's hear our great presenter. Please, you have the floor. You can now start. Thank you.
Okay. Good evening, everybody. Good evening, Hapan and Sipan schools, all senior members of Sipan and Hapan. Good evening, everybody. My name is Dr. Emmanuel Chibogu, and I will be making a presentation on ARFID. It's actually pronounced ARFID, Avoidant Restrictive Food Intake Disorder. It's not a very, very common condition in our climate. It's even a recent addition to the DSM-5, so it's not that common. So, hello, can people hear me? Am I audible enough?
Yes, you are.
Okay, thank you. So I'll be giving the presentation from, I'm actually in camp at Nasarawa State. So that's why I'm actually outside and I'm dressed in my white. So sorry for the background might be terrible. And it might not be very, the lighting might not be very okay, but this is just what I can manage now. So, moving on to the topic, avoidant restrictive food intake disorder. So this is my outline. I'll be giving you an introduction, a definition, symptoms, epidemiology, etiology, comparison with other eating disorders, management of ARFID, role of a pharmacist, and conclusion. So, introduction. Avoidant restrictive food intake disorder, ARFID. So subsequently, I will not be using avoidant restrictive food intake disorder. I'll be using the short term ARFID. It is among the recent diagnoses added to the DSM-5 and also the World Health Organization's classification of diseases, that's the ICD-11. So the DSM-5 is actually a publication of the American Psychiatric Association. It provides diagnosis for mental health conditions and is widely used by clinicians and also psychiatrists to diagnose and also give treatment to various mental health disorders. It's actually a world standard psychiatric health manual for clinicians and also health professionals. while the ICD-11 is more of the WHO version, WHO version of a diagnostic manual, but the ICD-11 contains both mental health disorders and also general diseases. So ICD-11 was added into the ICD-11 in the year 2018 when that version was released, but it entered into the DSM-5 in 2013. Um, it was introduced in 2013 and it presents a information of what used to be called selective feeding disorder of early infancy or early childhood. So it had various other names previously. It used to be called early selective feeding disorder of infancy or early childhood, also food neophobia, selective eating disorder. ARFID, as we all know now, is a condition in which patients, usually children, they avoid food based on the actual physical characteristics of such foods, such as the texture, the smell, and the appearance, or based on past negative occurrences such as choking or vomiting. So in ARFID, patients are actually avoiding foods, or the people that suffer from ARFID, they avoid food based on the physical characteristics of the food. So they might not necessarily, they might have a past experience, a negative feeling, a negative occurrence that happened before, maybe as a result of eating such food. So such occurrences make them to want to avoid or not to even eat those foods. Okay, let me go to the next slide. So let me come to the definition of ARFID. ARFID is an eating or feeding disorder in which people avoid eating certain foods or restrict their diets to the point that it ultimately results in nutritional deficiencies. This can be due to the sensory characteristics of foods, such as its appearance, its smell, its texture, its taste, or due to fear of negative consequences, such as choking or vomiting. Having little interest in eating food or a combination of these factors. So this is the definition given by the American Psychiatric Association for ARFID. So from the definition, I highlighted some important parts of it. The first part I highlighted was nutritional deficiencies. So in ARFID, the patients, due to their restriction of food, they come down with nutritional deficiencies. They are now living below their nutrition level is now very, very, very low. So, and this nutritional deficiency is due to the characteristics of the food. Such characteristics can be the taste, it can be the texture of the food. Maybe it is hard, or it is too mushy, or it is crunchy. So those textures of the food can make them to have a negative feeling of the food. So they will not want to have such foods. Some of them is the smell. They might not have, or the smell might not be appetizing to them. So as a result of that, they literally avoid such food. They don't want to have anything to do with such foods. And it gets to the extent in which they are now nutritionally deficient. So you see them lean, they lose weight. Um, you see children losing more than 5% of their weight within 6 to 12 months. Then some of them, they are below the fifth percentile in their weight category. So AFID is defined as a persistent disturbance in feeding or eating that can result in severe malnutrition, significant weight loss, or failure to gain weight. So the significant weight loss is um, them now having below normal weight. They lose weight within 6 to 12 months. You can see them losing up to more than 5% of their weight. So, or as children, they will not be able to get to attain their normal weight. It's actually a very, very serious health concern and is mostly diagnosed in children, although AFID has been also shown to be present among adults. So for the WHO definition, you can see that there's a part whereby it says that there's a marked interference with psychosocial functioning. I would like us to remember the definition of health. The WHO defines health as a complete, total physical and mental well-being, not merely the absence of diseases. So, ARFID in this condition, it affects the psychosocial functioning of the patient, such that they are psychosocially affected. They are not able to relate with their family members because maybe they are lacking, they are not eating such foods. You can take, for example, maybe in a festive period whereby everybody's eating a certain kind of food, and such children are just there because of AFID. They might not really be able to integrate or blend with other persons, or maybe they want to visit their friends or they visit other persons, and they cannot actually have a favorable relationship with those persons because of AFID. So it leads to a decrease in their self-esteem. It lowers their self-esteem to a large extent. So that is one part of AFID that is actually very, very vital, and you should also take note of. Let me go to the next slide. So for the diagnosis of AFID, the DSM-5 has the criteria for diagnosing AFID. So according to the DSM-5 diagnosis of AFID is an eating or feeding disturbance that leads to about four things: a significant nutritional deficiency and weight loss. It also leads to enteral dependence on enteral or oral nutritional supplements. It also leads to marked interference with psychosocial functioning. So, after that, eventually leads to either one or more of these listed criteria. So, a patient can be diagnosed with AFID if one of them is present, or if he has a multiple of those ones. But at the end, you see that it does not occur exclusively during the course of anorexia nervosa or bulimia nervosa. So anorexia nervosa and bulimia nervosa are more of like the eating disorders that we are more common with or conversant with. In fact, previous some diagnoses that are actually made for anorexia nervosa and bulimia nervosa are actually diagnosis for AFID, not actually for bulimia and for anorexia. So this does not occur during the course of anorexia or bulimia. So there is no evidence of disturbance in the way in which one's body's weight is or shape is experienced. Because in anorexia nervosa and bulimia, the patients are actually avoiding food because they are not they are avoiding food because they are not comfortable with their weight, or maybe they don't want to gain excess weight. So they're actually minding their food, the food they are eating, because they want to maintain a particular weight, a particular shape of their body. So that's the reason why they are avoiding food. But in AFID, it's not because they are actually trying to watch their body weight. It's actually because they don't actually like the foods. So let me try to explain some of the points. Significant nutritional deficiency and weight loss. So earlier I was trying to explain significant nutritional deficiency. So for you to consider something to be significant, for the deficiency to be significant, it means that the child or the adult has lost about 5% of their weight within the span of 6 to 12 months. So it's actually a very, very rapid loss in weight. Or maybe for a child in which the percentile of the child is less than the fifth percentile. So that child should be said to have drastically lost weight, because the normal percentile for a normal child is about 50%, 50 percentile. So from 50 percentile, the child is said to be having normal weight. But when it now goes above 95 percentile, the child is said to be overweight. But once it's below 5 percentile, the child is said to be seriously underweight, and it's actually a cause for concern. All that can go as far as depending on enteral feeding and nutritional supplements. So there are various kinds of enteral feeding that are actually used for AFID patients. You have the nasogastric tube, we have the nasoduodenal tube. In these tubes, in these in these enteral feeding methods, you could either use the pump or the gravity method for feeding the child. In sometimes they might place the child on maybe single bolus enteral feeding using the pump method, or they could use intermittent feeding using the um, gravity method. So um, the the nutritional supplements could actually be tailored to suit the patient depending on the deficiency that the patient is experiencing. Because ARFID does not actually cut across all foods. It's actually certain kinds of foods or certain types of foods. So there are some nutrients that the patient may actually be actually in severe lack of. So the dietitian will actually have to um, give the patient such nutrients in those foods. Some of them might be high protein foods, high carbohydrate foods, or or a combination of other classes of foods to give the patient a balance of nutrients that the patient actually needs. Then you also have the marked interference with psychosocial functioning. So this marked interference with psychosocial functioning is actually the relationship the patient has with either their family members, their friends, their relatives. So this function is actually affected because the patient has AFID. The patient will not be able to relate freely or be able to have good interactions with their family members because of the food that you can imagine if everybody in the family eating rice and the patient because of AFID cannot have rice or rather want to have another kind of food. So it will not allow for bonding that should exist between family members. And the child may actually now start looking down on himself or herself. So that's it for the diagnosis of AFID. So when a doctor or a physician sees all these characteristics or these symptoms in the child, it's actually a precursor for or a signal that this patient will actually be having AFID. Okay, so here are the various symptoms of AFID. So in the symptoms of AFID, I classified it into both behavioral, psychological symptoms and as well as physical symptoms. So for the behavioral and psychological symptoms, we have fears. These symptoms are actually as a result of um, the experiences that the child or the patient has actually experienced aforetime. So it might be maybe as a result of eating some certain kind of food, you see that the patient has discovered that whenever I eat kind of food, I end up choking. Whenever I eat this kind of food, I end up vomiting. So naturally, the patient will just have an avoidance of that food. So whenever that food is put before the patient will not will not even want to eat because of previous experiences, negative experiences. So we also have other symptoms of picky eating that becomes worse. In picky eating, some children might actually have picky eating in that they will want to eat certain kinds of food and they will not want to eat other kinds of food. So in picky eating is actually a kind of eating disorder too, but it's different from AFID because in AFID is more of like a picky eating that becomes worse because the child might start by selecting some certain kinds of food, but with time, it's that the ranges of food that the child is now selecting is now increasing and increasing by the day. So it's also an indication that the child might be having AFID. Then you have limiting food intake due to particular textures. So the patient might not want to eat certain kinds of food because of the texture. Maybe the food is too mushy, or the food is too strong, or it's too hard. So various textures of the food might make the patient to have an aversive effect or an aversive response to taking the food. Then reports of consistent, vague gastrointestinal issues. So this one is now going psychological because of the previous experiences that the patient has had. So whenever the patient is having or is seeing or perceiving such kinds of foods, the body will start just developing some vague symptoms that the patient can actually really explain. So those symptoms will make the patient to even have more aversion towards eating the food because the body is now programmed in a way that it does not want to have any kind of food. So it's actually pushing it away. So some physical symptoms that can have come as a result of ARFID might be stomach cramps and other gastrointestinal symptoms. So in this one, the patient might just be having cramps. Once it's time for food, or once the kind of food is placed before the child, the patient does have having serious cramps and cannot just explain it. Then cold intolerance. Intolerance might be due to the patient not having sufficient food or due to reduced metabolic activities because the patient is not eating well. So the patient cannot be prone to cold and can easily have intolerance. So menstrual irregularities could also happen. In menstrual irregularities, we discovered that some female patients will not have, they will not see their period, except maybe they are now on other hormonal therapy before they will to see their periods. This is could also be an offshoot of ARFID. They have difficulty concentrating because the brain is not having sufficient food supply and sufficient nutrients. The patient might be having difficulty in concentrating. Then you have dizziness or fainting, which is due to lack of energy. Then we have some sleep-related issues. We have fatigue. We have dramatic weight loss, as I've earlier explained, and faltering growth. Faltering growth is experienced in children, while dramatic weight loss is experienced in adults. So the next slide. So let me go to the epidemiology. So in the epidemiology of ARFID, ARFID occurs in people of all ages and genders. So previously, it used to be called early infant eating disorder. So it was previously categorized as a disease of infants and not adults. So, but it has come to be known that it affects actual persons of all ages and all genders. So it's often diagnosed in children and adolescents and may progress into adulthood. So estimates of the prevalence of ARFID using population-based studies range from 0.3% to 4.8% across different countries, from Oceania, North America, Africa, Southeast Asia, Europe, and the like. So it's actually having, due to the because it's actually a new kind of eating disorder. It is not the epidemiology is not well substantiated yet. It has not been fully exploited like all over the world. So most of the statistics we have currently are actually based on those in America. So in other parts of the world, it's not actually well documented, especially in Africa and Nigeria. So ARFID also is more common among males and minority groups and those from lower income countries. So it's common more among males because males may be more prone to, they have more um, um, they might have more sense of taste and also smell compared to females. Then it's more among minority groups because the minority groups may be due to because the minority group they might not be really integrated into the culture or the culture of the place that they stay. You can take for example, maybe in the north, for example, in the northern part of Nigeria, where you have more of northern persons. So if you now have, let's say, if you check the Christians there, some of them might actually be having ARFID because the kinds of foods that they may be eating might not actually be actually what they are used to. So the geographical differences might actually make them to have they it may make them not to be let me say to really accept the kinds of food that they may be exposed to there. So they rather want to maybe go back to where they come from, or let's say those that are even outside the country. Those are outside the country. So the kinds of food that they might be exposed to, they may not be actually what we are actually used to. So it may make them to be prone to ARFID. So they will fall under the minority groups. Then those of low income countries might be actually due to because they cannot afford they cannot they have poor access to um health facilities. So they might not really be able to get proper treatment. So that's why it might also be more common among them. So in Nigeria and West Africa, ARFID appears somewhat underreported as a result of under diagnosis and misdiagnosis of ARFID and its comorbidities. So among the causes of ARFID, among the symptoms of ARFID, no, not really symptoms, among um, the let me say a more of like a precursor for ARFID are also comorbidities. Some comorbidities that might be common with ARFID is autism spectrum disorder. So autism spectrum disorder is actually a disorder that's still not well diagnosed in Nigeria. So patients with autism spectrum disorder may also come down with ARFID. So because also health professionals are not aware, they don't know of ARFID, they don't know of its existence or if of its symptoms. So they tend to diagnose ARFID for other conditions. So this has led to it being underreported. So the patient may actually be having ARFID, but because the doctor or the physician is not aware of does not know about ARFID, so the physician may actually diagnose another condition for the patient. So this has led to the poor epidemiological data for ARFID in Nigeria and also Africa. So let me go to the etiology of ARFID. So for the etiology of ARFID, we have the genetic, the social and cultural, and as well as the psychological etiology of ARFID. So under the genetic etiology of ARFID, we have the molecular hereditary. So this one is it should be expected because most health conditions are actually genetic in nature. So there's a possibility of it being familial. So a family that has either these comorbidities, which is anxiety and autism spectrum disorder, might also have some persons that might come down with ARFID. So or maybe other family members that might have had ARFID before. So going down the genetic line, so some persons might actually come down with ARFID because of their genetic traits. They also have social and cultural. So this one has to do with both health appearance expectations as well as environmental influence. So for environmental influence, some persons might be influenced by their environment, might be by their family members, might be by their friends. So this influence might make them to actually develop ARFID. So maybe somebody's staying around person that has does not allow for some foods, or let's say a religion that does not allow for some foods. For example, some persons might call some foods to maybe be unclean and not good for eating. Some persons, or for example, now in China, in China they readily consume some animals and some insects. But in this part of the world, in West Africa and in Nigeria, we might find those kinds of food to be repulsive. So those are some kind of environmental influence that could happen. Then we also have the psychological, the psychological etiology of ARFID. So this has to do with the comorbidities that could be associated with ARFID. So a patient that has the obsessive compulsive disorder could also come down with ARFID. And also a patient that has anxiety could also come down with ARFID. Because in the definition of ARFID, we could know that I said earlier that ARFID could be as a result of fear. So a patient that has fear, anxiety generally could come down with ARFID. So it's just that the direction of the fear might not actually be towards food, but with time, the patient can actually develop ARFID towards food. That's the fear of vomiting or fear of choking. So this could be an etiology for ARFID. Let me go to the next slide. So in this slide, I was trying to have a differential diagnosis of other eating disorders that might be mistaked with ARFID. So there are actually three major disorders that we actually know of. We have the anorexia nervosa, often called anorexia. We have bulimia. We have binge eating disorder. So these are just like three. There are actually more eating disorders than this, but these are like three major eating disorders that we might be actually be used to in this part of the world. So for anorexia nervosa, often called anorexia, so a patient is trying to control their weight by not eating enough food or exercising too much or doing both of them. So in anorexia nervosa, the patient does not want to gain weight. So because the patient does not want to gain weight, the patient is restricting their food because they don't want to gain weight. So there's a reason. The reason is because they don't want to gain weight. So that's why they are restricting their food, or they are not exercising too much. So you see in such patients, they are losing weight excessively. They lose weight excessively. So this is actually more common among our female folks because they have maybe they have a version of what they feel to be a healthy female body. So they want to actually maintain or keep to that shape. So if they don't have that shape, it leads to the reduced self-esteem. So in a bit to have a higher self-esteem, they deliberately lose weight by not eating food or exercising. However, in bulimia, the patients lose control over how much they can eat. Then thereafter, they take drastic measures not to put on weight. So in bulimia, the patient actually eats. The patient can actually control how they eat. They actually have love for food. So when they start eating, they just eat and eat and eat and eat and eat and eat. So after they finish eating to their satisfaction, they now discover that this kind of food I've eaten now it might lead me to having increased weight. So they're actually still concerned about their their body. So what they now do is that they now take drastic decisions. So they could take purgatives. Some of them could even go as far as inducing vomiting so that they can vomit the food, all in the bit not to lose weight. But this is actually in bulimia, the patient does not actually gain weight excessively. The patient that it has been discovered from research, it has shown that in bulimia patients, they actually maintain their normal weight. They maintain their normal weight. Um, they maintain their normal weight. But in anorexia nervosa, the patient actually loses weight drastically. So that's for bulimia. Why for binge eating disorder? In this condition, they eat large portions of food until they feel uncomfortably full. So these patients cannot actually control the way they eat. So they just eat and eat and eat and keep eating. They just keep eating and eating and eating and eating. So those are three other eating disorders that might be more we might be more familiar with, unlike ARFID. So let's go to the types of ARFID. For the types of ARFID, we have the avoidant. In the avoidant ARFID, the patient is actually um, having fear of choking, fear of vomiting, having issues with swallowing, or all these factors together. So in avoidant, the patient is actually avoiding food. This has to do with the physical characteristics of the food or the way the patient perceives the food. So the patient is avoiding food because of all this. No, this is actually aversive. So in avoidant, they avoid food based on the physical characteristics of the food, such as the texture, the smell, the taste, and the like. So the patient avoids food because of all these conditions of the food. So they may have they may feel the smell of the food can make them to not want to eat the food, or actually the texture of the food. So they are avoiding the food based on this physical texture and characteristics. So in these patients, you could actually modify the kind of food that they actually eat. So maybe if they don't like hard food, you can make the food to be soft, and maybe they will be able to eat the food. But for aversive, they have had a previous negative effect of the food. So that previous negative effect of the food is making them not want to eat the food. So they might have had choking experiences. They might have had vomiting experiences, or maybe pain as a result of eating the food. So whenever they are now exposed to such kinds of foods, because of those previous experiences, they have an aversive nature towards those foods. They will have the restrictive. In the restrictive um, kinds of type of ARFID, the patient may show signs of no appetite, get extremely distracted during eating. So, so they may show signs of little interest in eating the food. So they may not actually be feeling interested in the food, or they may be get distracted easily. That's in the restrictive aspects, or they may have extreme pickiness. They will not want to. They may actually be selective of the kind of food they eat, the way the food is prepared, the manner it is presented. So all these things can actually affect the way the patient might want to eat. So this, if the patient comes down with this kind of behaviors, you could say this is actually a restrictive type. They will also have adult ARFID. So all these earlier ones, the avoidant, the restrictive, and the aversive, they are more or less diagnosed in children. So whenever you have these symptoms, either one or both or all of them in children, in adults rather, so they have their own type. So it's not called adult ARFID. So an adult ARFID might either be avoidant, might be restrictive, might be also be aversive. So we also have ARFID plus. In ARFID plus, the patient experiences more than one of the types of symptoms. So they might be having avoidance, might be having aversive, might be having avoidance and aversive, avoidance and restrictive. So whenever more of these kinds of symptoms is being exposed, is being experienced, so that's when you now have AFID plus. So the patient may even be having other eating conditions too. So the patient might have AFID plus anorexia nervosa or AFID plus bulimia. So that's what we categorize as AFID plus. So let's go to the management of AFID. So in the management of ARFID, we actually we develop a multidisciplinary action because ARFID is a condition whereby you need the whole health team to be critically involved in. You need both the physician, you need the psychologist, clinical psychologist, you need the a dietitian, you need virtually everybody in the health team. So we actually adapt a multidisciplinary approach. And moreover, the pharmacological approach to managing AFID has not actually been fully, it has not been fully or completely um, um, accepted yet, or let me say it has not been fully declared. So the more acceptable methods are actually psychological methods. So in the treatment goals, we have a personalized plan by a dietitian and use nutritional supplements as well as nutritional rehabilitation. You have medicine that can help the appetite or ease anxiety. You have medical and psychiatric stabilization. You have cognitive behavioral therapy, family care giver involvement, and you have weight restoration. So these are the treatment goals for the management of AFID. So subsequently, I'll also be explaining these treatment goals. Look at the next slide. So in the management of AFID, we have the non-pharmacological management. So for the non-pharmacological management, we have the cognitive-based therapy, which is also called the CBT for AFID. So in cognitive-based therapy for AFID, so we actually this part of the management of AFID is actually done by the psychologist, clinical psychologist. So the psychologist is not trying to address the root cause of AFID, which is actually the fear that the patient experiences, the fear of vomiting, the fear of choking, or actually the perception, the way the patient perceives those kinds of food. So the psychologist could have various meetings and various plans in which is trying to address these symptoms that the patient is experiencing. So this is actually the gold standard for management of AFID. You actually use the cognitive-based therapy. So the other methods of managing AFID, including the pharmacological method, are actually adjuncts to the non-pharmacological management. So the cognitive-based therapy is actually the gold standard. So it's actually based on counseling and psychology. That's how the patient actually gets to recover. Then we have family-based therapy. This is also a kind of non-pharmacological management. In family-based therapy, the psychologist can actually decide to train the family members of the patient, because it's more experience, it's more diagnosed among children. So The parents could be trained on how to manage the child whenever he's experiencing such symptoms of ARFID. So it could be given advice. They will be trained on how to help their ward or their child. Then we have nutritional supplementation by a registered dietitian. So in this one, this is usually when the patient is under very, very serious ARFID condition. In this situation, the patient is usually on admissions. So the patient is now giving it's not giving supplements, not giving nutritional supplements using the nasogastric tube or the nasoduodenal tube or other forms of enteral enteral feeding methods. So the foods that are given are actually liquid solutions that contains all the classes of, like I've earlier said. So it could either be the pump gravity feeding for intermediate feeding or the it's either the pump and the gravity feeding. So the gravity feeding is usually used for bolus feeding. In this kind of feeding, the oral supplements are actually hanged and is given at intervals, maybe in the morning, the afternoon, evening. So at those times, the bolus dose of the nutritional supplements is actually given to the patient, while the pump method is used for intermittent feeding. So in this one, the patient could have um, meals up to 4, 6 times in a day using the pump method. Let me go to the next slide. So coming to the pharmacological management of ARFID, we eventually use the atypical antipsychotics for the management of ARFID. For example, olanzapine. So this we use olanzapine because it is actually because of its um, um, it actually helps the patient to actually gain weight and actually loses the okay, olanzapine basically helps the patient gain weight. So that is why it's actually being used in the management of ARFID. Then it also helps to address some of the anxiety that the patient might experience. Olanzapine acts by binding to serotonin receptors. So in binding to serotonin receptors, it helps to increase the appetite for the patient and also helps the patient to gain weight. Then we have mirtazapine and buspirone. Mirtazapine and buspirone. Okay, olanzapine is given at a dose of about 2.5 to 5 milligram. It's actually given once daily. It's given once daily for children and might be given from 5 milligrams depending on the severity. So it's actually started at 5 milligrams for adults and titrated upwards depending on how the patient is recovering. Then then for children, it's usually given from 2.5 to 5 milligrams as a single dose, usually given at night. Then mirtazapine and buspirone. Mirtazapine and buspirone is given because of um, it helps to reduce anxiety around food. So it's actually an anxiolytic, and um, when the patient is on mirtazapine, it helps to reduce the anxiety the patient experiences whenever food is placed before the person. So, like I said, these pharmacological methods are actually adjuncts. They are adjuncts to actually managing ARFID. They also have selective serotonin reuptake inhibitors. So these ones they are used because of the anxiolytic effect. So they are used because of the anxiolytic effect. So they help to manage symptoms that the patient is experiencing. Then we have atypical antipsychotics. Um, ARFID, if not managed, because it comes with anxiety and could lead to depression. So if not managed, it will actually worsen into depression, very, very, very serious depression. So it's depending on the severity of the condition, the patient will actually be placed on SSIRs. SSRIs, and also typical antipsychotics. Because when the patient is now on full-blown depression, we also now um, switch to bipolar disorder. So depending on the stage in which the patient is, the stage of the condition, the patient can actually be placed on typical antipsychotics. They also have antiemetics such as cyprohepatidine. So these ones help to manage the vomiting symptoms experienced by the patient and also the lack of appetite. So these are appetite stimulants that help the patients to actually gain um, appetite. So that's for the management. So the role of pharmacists in managing ARFID. So we have medication counseling. Due to the drugs that the patient is on, the patient actually have to be counseled and actually um, monitored on proper time to take the drug and also how to take the drug. And also um, the pharmacist should also help to monitor the efficacy of the drug as well as interaction and side effects because these drugs are actually they are antipsychotics and antidepressants. So the symptoms of the drugs might not be um, palatable or pleasant to the patient. We know of the EPS that comes with typical antipsychotics, although it's reduced. But the pharmacist could enlighten the patient, although for ARFID, it's actually given as a low dose. The patient may not actually experience it, but the pharmacist could do a good job by enlightening the patient on possible side effects and also drug interactions. Then we have optimizing medications for medicine adherence. So the pharmacist will also play a role in helping the patient to actually adhere to their medicines. Then we have optimizing patient's quality of life and medical advice. Then we have for monitoring for altered pharmacokinetics and for adverse effects. We also have facilitating appropriate referrals. So in AFID, first point of call for the patient will actually be the pharmacist. So the pharmacist that now have to refer the patients to link other health professionals, the clinical psychologist, the dietitian, the physician also. So the pharmacist can help to facilitate appropriate referrals to help the patient that has come down with AFID. Then also for advocacy and promoting awareness among public and health professionals. Like I said, it's not actually well known. It's not yet a common condition in Nigeria. So as pharmacists, we do a we promote awareness among the public and also health professionals. So to help to actually um, help for proper diagnosis of the condition, patients that are having it, and also um, to um, it could also okay when we develop awareness among health professionals to help us to make the patient to actually recover quickly. Then we also have research and development. So it's actually still a new condition. It is the research and development. The research in this area generally is still not very 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 strong. So there's actually a niche that we actually create in this AFID. So there's room for research, there's room for development for AFID because it's actually a condition that we might not actually know of, might not actually know, but it actually exists in existence, and many persons are actually down with it, and they might have been misdiagnosed, or maybe they don't know what's actually wrong with them. So with this, you can be able to know that this actually exists, and we can watch out for it when we see patients like that. So in conclusion, AFID is an eating disorder that's often associated with psychiatric comorbidities, especially with anxious and obsessive compulsive features. It usually starts at younger ages than other eating disorders and is more common in males. And most victims of AFID can be treated at home, but some will need to go to a more intensive hospital-based program, especially patients with severe weight loss and malnutrition or serious health issues. Then ARFID can also be hard to overcome, but learning about healthy eating and addressing fears may help patients feel feel better and do well. So these are my references. And thank you all for listening. People are getting changed from their circumstances and situation, and there are brothers and daughters testimonies we are having, but one of the best testimony what I found that
Thank you.
2 years old child who was born and she couldn't walk. So I'm looking for questions. If people have any questions that
Thank
you
you,
might
our dear.
want to
Have wisdom.
ask.
Hello.
Hello.
3, 2, 1.
Thank you, our dear presenter, for a wonderful work. Can you hear me, please?
I can hear you, ma'am.
Am I audible?
Yes,
Okay,
ma'am.
thank you
hear
so much, our dear presenter. Wow. I don't know where to start. So I was busy jotting, because it's actually new topic for me, and I know for majority of our listeners tonight. Wow, ARFID. I can tell you this is my first time of hearing this type of disease states. Okay, so he really did a good work. He started by giving us the definition by the WHO, and he went further to give us the diagnosis, the symptoms, the physical symptoms, epidemiology, etiology, and as well different types of ARFID. He said avoidance, aversive, restrictive, adult ARFID. Wow. And furthermore, he made us understand the management. We have the non-pharmacological management and pharmacological management. And he ended with the pharmacist rules. I don't want to start to recap what he said, but let's just move straight to questions and answers. Okay, let me see if we have new. I can see our dear National Auditor, Dr. Rita Ukeredu. You're welcome, my dear. Okay, so it's time for question. So if you have a question, kindly raise your hand so that I can identify you. Questions, please. Raise your hand, please.
My hand is raised, ma. Hello?
Hello. Hello,
Can you
ma'am.
hear me? Can you
I
hear
can hear
me?
you.
Okay. Thank you. Thank you very much for your presentation. Like Dr. Morin said, it's actually something new. Thank you for bringing it to fore. So I would like to find out, like we always want to do, does non-pharmacological measures, does it work for ARFID, or it has to be pharmacological way of managing it? Thank you.
Okay.
Okay. Please, you can answer the question.
Okay. Non-pharmacological methods are actually the gold standard for managing ARFID currently. The pharmacological methods are actually used to just manage symptoms. So pharmacological methods are actually an adjunct in treating those with ARFID. So the first point of call when it comes to managing ARFID is actually the enough management methods in which the patients actually need to maybe try to face their fears or try to combat the reason why they're having such aversive nature or avoidant nature to foods. So when such is being treated, then patient cannot be given
Recording in progress.
patient could be given drugs in addition to actually manage the excessive symptoms that might be associated with ARFID. Or maybe if the patient is actually having very, very, very serious ARFID condition, you can actually place test on maybe antipsychotic or antidepressant, depending on the severity. Then when the patient has actually recovered a bit from his depressive state or psychotic state, then the patient cannot be taken to the non-pharmacological method, which is the cognitive-based therapy, which is actually the method I actually use to manage. So cognitive-based therapy actually works. It works, and it's actually what is being used to manage. So the drugs are actually just adjuncts, just help the patient to actually recover and do well in the long run. I don't know if I answered your question.
Thank you. Any other question? I can see Dr. Kingsley Amibo, former chairman. I have been. You're welcome, sir.
You're welcome, sir. You're welcome. Thank you very much. Thank you so much.
Okay. Any other question or contribution? Go ahead.
Oh, another number on your sending.
Who is talking, please? Okay, I have few questions, or do I say contribution to make? I give you a scenario. I have a daughter.
Okay.
She can never eat fish, no matter the type of fish it is or the type of menu you use that fish to cook. She cannot eat bitter leaf soup or rat soup. She can go hungry from morning to night if you say you can't give her any other food except those ones who cook on that fateful day. Yes, she's now up to 15 years. Even she's in the dormitory in school, she can never eat those things. Rather, she go hungry. Can I say that this is a type of ARFID or what? That's
Yes,
one. Okay, you can answer
Well,
this one.
you like from my slide, you can see that is your child actually losing weight? Is there a significant weight loss for the child? So you should also consider the weight. The patient might not be eating. There's actually picky eating. Picky eating is kind of eating disorder too. So it might actually be selective for some foods. That's picky eating. But when this picky eating becomes worse and now results ultimately in the patient actually losing serious weight, losing weight seriously, the patient can be said to have ARFID.
Okay,
But if it does not result in weight loss, it might not necessarily be ARFID. So if the patient has other foods that the patient can actually eat comfortably, then it might not actually be ARFID.
Please, I would like to ask question. I'm Malaki Chinonso.
Go ahead.
Adding to what she said, like me, I don't eat ogbono soup. I don't eat fish. Some fishes. Even if I force myself to eat it, I'll end up throwing up, which is one of the signs you give. And I'm not losing weight. Does it mean that I'm having ARFID or not? Like giving myself
you are not having ARFID. You are not having ARFID because you will lose weight. Then
there must be
you will
lots
also loss of weight is actually very, very important. In fact, some person might go as far as actually having enteral feeding. So they might actually lose weight seriously that they might have not have to depend on enteral feeding. So yeah, I don't think you're going to that stage. So since you are able to, you are having your normal weight and you're also going back to your normal life, it's just some foods that you cannot eat. So it might not really be ARFID, but it might be also be, it can also lead to ARFID. Such condition can also lead to ARFID. So maybe it may not be expressed in you now. Maybe like I said, it's genetic. Maybe it's not your children that might have or develop the real ARFID because of the genetic makeup. So you should just watch out for it. It's actually there. It's actually exists, but I'm not sure you have ARFID.
Okay, I still have another comment too.
Okay, ma'am.
Like some of us in community pharmacy, a patient walking, you can see him emaciated, lots of appetite. Most of us will start to look into other comorbidities, maybe HIV and AIDS. And, I can't never met that our mind will ever go to ARFID. So in that scenario, what should prompt us to really look into ARFID as in practical terms in the community pharmacy? Talk less of making a referral, because it's only when you get the right, the initiative that, okay, this may be ARFID, that we can now prompt to
I think in that condition, just have to do a history of the patient and actually check where the patient started behaving in such way. Is it something that just started of recent or something that has been there for a long time since when the person was small? So if it's since when the person was small, then it would be an indication of ARFID. But if it's just something that's just maybe of recent, then you can now actually check other conditions that might be related to that can cause such conditions like HIV, like you said. But if it is from way back, right from when the child was small, then it could be an indication for ARFID. So that's what I can say.
Okay, thank you so much. And you mentioned that those antipsychotic drugs can be used as an adjunct in managing ARFID patients. I'm wondering, those antipsychotic drugs, that they have so much adverse effects, if I may say, or side effects.
Yes,
And
you
when
have
it's used
you
as
have
an
you have
adjunct.
extrapyramidal effects, but
Yes.
they're actually given at a very very low dose. So at such doses, it's not actually patient may not experience such extrapyramidal effects as um, that's experienced. And these antipsychotics, they are they actually used to treat either when the patient is already in very 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 severe ARFID conditions, such that it's not developing into maybe bipolar, because it's ARFID will generally make the patient to come down with depression because of the nature of not avoiding, of not eating well, and also not being able to socialize and interact with their friends and colleagues. So the patient might come down with severe depression as a result of ARFID, and it might subsequently progress into full blown bipolar. So it's actually used in more serious conditions, but the dose in which olanzapine is given is actually at a very very low dose. In children, it's given from 2.5 milligram to 5 milligram. At such doses, possibility of developing EPS is actually very very low. Then for adults, it's given from 5 milligram, depending on the severity of the symptoms. So at those doses, it actually only checks the appetite and helps the patient to gain weight due to its receptor binding. So it does not actually invoke EPS at such low doses. It's like maybe at higher doses.
Okay. Okay, thank you so much. I can see Pharmacist Olumide Folorunso. Do you have a question? Your hand is up.
Yes, ma'am. Good evening, ma'am.
Go ahead. Thank
Good
you.
evening, ma'am.
Good evening.
Thank you, Farm Emmanuel. Thank you for your presentation.
Thank you, ma'am.
My question is, I didn't hear you mentioning all those stimulants, appetite stimulants, like cyproheptadine, dynamogen. Can we say when patients are using it, they are drug abuse? You know, they use them as an appetite stimulant.
Okay.
They are drugs like cyproheptadine.
Yes, I mentioned cyproheptadine in my slide.
Yeah.
It's actually used as an
Okay.
anti-emetic and also to help the patient to have appetite. It's among the we use it to treat the symptoms the patient is experiencing. So they are just symptomatic treatment for ARFID. So it's actually among the treatment.
Okay.
Okay, and dynamogen.
Dynamogen is
Dynamogen.
cyproheptadine. It contains cyproheptadine. So dynamogen. Yes, it will also help. But like I said, it's just symptoms to treat. To treat the lack of appetite that the patient might experience. But it might not actually address the fears and the aversive nature or the avoidant nature the patient might have towards eating such foods. So even if the patient might be hungry, if you still give the patient such kinds of food, the patient might not want to eat because of those fears. So that's why you actually have to incorporate the cognitive-based therapy to actually try to address such fears and also maybe give some other anxiolytics in addition.
Okay. Thank you so much. Thank you, Dr. Moon. Thank you.
You're welcome, my dear. We have a chat here. I think we've answered that question. He asks, if a person is selective to one particular food and no matter the situation, he or she won't eat it, is that considered as ARFID?
No, this is not considered as ARFID. This one will just be picky eating.
Yeah.
This one will just be picky eating. It's not actually ARFID.
Okay.
In ARFID, there's substantial weight loss. There's also nutritional deficiency. So even if the patient is not getting the necessary nutrients from that one particular food, he might actually get such nutrients from other foods. So that cannot be considered as ARFID.
Okay.
If there's no nutritional deficiency and there's no substantial weight loss, it cannot be categorized as ARFID.
Thank you. Any other contribution or question? Okay. Okay, we want to thank our presenter. Wow, at least I've learned a lot today. Tomorrow, if I see a pharmacist, I say, I know ARFID, most of all will still not know it. So we are privileged to have been in this clinical meeting tonight. At least we are going home with this term, ARFID, and we know how to manage it. Thank you so much, our dear presenter.
Thank you,
On this note, I want Dr. CRO to give a vote of thanks and close us with a closing prayer. Thank you. I want to congratulate Edo State. You put it well. Thank you so much. Our dear Public Relations Officer.
Okay, good evening, very distinguished National Vice Chairman of the Clinical Pharmacists Association of Nigeria. I want to congratulate the presenter for a well presented session. I want to appreciate the moderator herself. She did a very good job. I want to thank all our very senior members and of CPAN, very distinguished. I can identify past national chairman of AHAB, Dr. Amiwo, and a number of other who are very key to CPAN. I appreciate the time that we have spent in listening to our presenter. Sincerely, I have learned a lot. There's a lot that I have noted, which I'll take home. He mentioned a number of things that have to do with children, pediatrics, and that's my core area. So I can confidently say that I benefited most from this presentation. So on behalf of the Clinical Pharmacists Association of Nigeria, the national chairman, ESCO, and the council of CPAN. I want to appreciate every one of us for the time that we have spent listening to this presentation. It's one of a kind. It's not a regular. It's not a regular presentation. It's one of a kind, and coming from a COP pharmacist, it's really interesting. You know, a very young person who is a core member and taking this bold step to make a presentation right from the camp. It's really commendable. Must commend you for
exactly.
this. Yes, it's really commendable. And it's a challenging time for Nigeria, and probably that's why we don't have so many persons that joined the presentation. You know, the issue of hike in fuel price. Some persons may not have their phones on; they have to get their phones charged, and all of that. A lot of challenges, but those of us who have participated, we have sacrificed our time, we have sacrificed our resources. We just want CPAN to succeed. Apart from gaining knowledge, we want CPAN to succeed, and that's why we are here. So I want to commend all of us for the efforts that we have made to be in this clinical meeting. We're hoping that we're going to meet again at the next appointed time. Thank you very much, and God bless us. So, like I've been assigned to take the closing prayer. Can I go ahead with that?
Go ahead, sir.
All right. Our Father in heaven, we want to thank you for the success of this presentation tonight. We want to thank you, Lord God, for all that you have been doing for CPAN, for bringing CPAN this far, for everything that you have helped CPAN to achieve to this point. We give you all the glory. We ask that you give the leadership of CPAN more grace, more wisdom, more knowledge, and more strategies to take CPAN to the next level. And we pray that all the efforts that we make together as members of CPAN, we pray that they will yield fruitful outcomes to the glory of your name. In Jesus' name.
Amen.
Amen.
Thank you. Thank you. Thank you, everyone. Good night and enjoy your night sleep. Thank you.
Thank you. Yeah, good night, everyone.